Greetings, I'm Dr. Noor-ul-Huda, and I'm really pleased to welcome you all to this course on basic neuroanatomy. I think that this course is quite basic, but it contains some important points of clinical relevance. So why neuroanatomy is really important? Of course, it can help you in so many ways, and I think in from the very start to the very end, it is helpful for you to manage your cases quite well because when the patient presents to you, it helps you to locate the lesion and maybe for you to guess what might be the nature of the lesion. And of course, during surgery, it's incredibly important to know for you to know the exact neuroanatomy, of course, for surgical planning and for exact, picking up the approach for your particular lesion, and obviously to know what the delicate areas are and how to avoid any complications, and also to have an idea what the complications might be. So I think that neuroanatomy is extremely important for you to learn. And I'm not going diving not deep into that, not much deep into that. I think at least in my opinion, this is what we really need to know, and it is basically all those important points that we should know. So I think that you will like this course, and I'm looking forward for your further suggestions and feedback so that I can modify the course accordingly. So, okay, first of all, we should go into some sort of brief introduction. So, the divisions of nervous system. There are two main divisions, as we all know, but it's just for a revision. That the central nervous system, which comprises the brain and the spinal cord, and the peripheral nervous system that comprises of groups of neurons called ganglia and the peripheral nerves, and they provide pathways to and from the central nervous system for electrochemical signals, the impulses. The peripheral nervous system composed of two divisions, the somatic division that provides sensory information, there's voluntary information, transmits impulses to and from the skeletal muscles, usually conscious actions, and the autonomic nervous system, which comprise of motor system for viscera. So here we are just going to, go through briefly just a little bit of revision and introduction. When we say the nervous system, there are two subdivisions: the central nervous system that comprises the brain, the spinal cord, the peripheral nervous system that comprises of ganglia and peripheral nerves. And obviously, the central nervous system comprises the brain and spinal cord, with brain having parts of cerebrum, cerebellum, diencephalon, brainstem comprised of midbrain, medulla, and the pons. The peripheral system comprises the somatic and autonomic divisions, and there are the supporting cells of the nervous system, and there which are non-conducting cells, and they are collectively referred to the neuroglia, comprised of astrocyte, microglia, Schwann cell, oligodendrocytes, and they provide mechanical support and serve as insulator and prevent neuronal impulsing from spreading into in water directions. And these are the protection of the brain and the CNS. The skull and the spinal cord, the three meninges, the three layers of the tissue protecting the brain. That includes the outermost dura, which is an outer tough layer, and below the dura, between the dura and the arachnoid lies the subdural space, which is normally it is just a potential space. And subdural space is basically more important in the elderly age group where it is in the brain shrinks and it causes, pull on the veins, the dancing veins, and that might be lead to, the collection of blood in the subdural space. The chronic subdural hematoma that you might have heard about in elderly is because of the same reason. Outside the dura is a potential space called the extradural space that lies between the dura and the surface of the skull. So when you deal with the younger age group, then you have more, incidents of traumatic extradural hematoma because it's a potential space there. But in the elderly, it gets adherent, the membrane gets, the dura gets adherent. So the potential space is no more there, not not quite very. So you are not going to have more. You are not going to see more exterior hematomas in the elder age group. So it is important to point over here. We will discuss it later. Then below the dura we have the arachnoid membrane, and it is the extradura, and there are the subarachnoid spaces, the spondyloid covered with CSF in the blood vessels. It is very, very important. The subarachnoid space is extremely important, and we are going to take up this in later in detail, because it's something that we need to know about as surgeons. And the pia mater, that is membrane that covers the brain, and CSF obviously cushions the brain, circulates around the brain and the spinal cord. So moving schematically, moving schematically, we will start from the outermost layer, the scalp. We Because it is something that we deal with as neurosurgeons when we operate, and we have to make this incision over the skin and the scalp. So we think that it should be first taken up. So scalp is just imagine scalp as a mnemonic. The outermost layer is the skin, that the S stands for skin, and think that C stands for connective tissue. Underlying connective tissue is the aponeurosis, and then below the aponeurosis is the loose areolar tissue, and the last layer should be pericranium. So the dangerous area of the scalp is the loose connective tissue, and it is called the danger area of the scalp since it contains the valvulus and visceral veins, which constitute potential pathway for the spread of infection from the scalp and the intracranial space. So this is a point of clinical relevance that you should be aware of. So another important point that I wish to mention here is the arterial supply of the scalp. So the other thing is that the scalp wounds tend to gape because of all the muscular layers, and I will just take this topic up again in detail. So this is another thing, but the other important thing that I need to tell you is about the rich arterial supply of the scalp, and this is the reason why scalp wounds generally heal well. But you have to be extremely careful about it, because you are supposed to try not to damage the vessels, and because the supply of the arterial supply is genius, a little bit middly, so you have to basically design your flap in a way that the base is towards the periphery. So we will discuss it later. So there is a rich arterial supply via the external carotid artery and the ophthalmic artery, which is the branch of internal carotid artery. So in this way, you are having external carotid supply, and via ophthalmic artery, which is the branch of internal carotid artery, we are having this supply from the internal carotid too. So there are three main branches of external carotid artery which are involved. Number one is superficial temporal artery, and we all know about it very well. If you are operating, you must you have felt the pulses of superficial temporal artery, which supplies the frontal and the temporal area. And then we have this posterior auricular artery that supplies this area superiorly and posteriorly to the auricle, and the occipital artery which supplies the back of the scalp. So you can see it here. The red one is the superficial temporal artery, the yellow one is the posterior auricular artery, and the green one is the occipital arteries. And these are all supplied through the external carotid artery. These are branches of the external carotid artery. Anteriorly and superiorly, the scalp receives additional supply from two branches of the ophthalmic artery, and these are the supraorbital and the supratrochlear arteries. These thus accompany the supraorbital and the supratrochlear nerves, respectively. This is a slide which I have actually taken from thanks to Neurosurgical Atlas, and I really wish to show this to you. So these photographs show two of the Harvey Cushing patients who suffered from post-operative fungus cerebri, that is the ulcerated brain herniations through incompletely healed incisions. So Cushing's meticulous compulsion for strict aseptic Hausterian's handling of wounds minimized the dreadful complication to allow neurological surgery to survive with advancing in the face face of its critics. So this is image courtesy of the Cushing Brain Tumor Registry at the Yale University, and I have taken this thanks to Neurosurgical Atlas. So these are some of the points that I have already mentioned, that always incise the skin perpendicular to its surface. Plan the incision within the hairline, and if the patient is bald, then you have to plan accordingly to that area, which is the anticipated area behind the hairline in a person who has got hair. So you can just assess it, that the area which is not quite visible from the very front in the bald person, you have to pick it up wisely so that it doesn't look cosmetically bad. So during closure, the suture needle should enter perpendicular to the surface of the skin, and the sutures need to be placed at equal distances and depths of the edges, to avoid any inversion of the skin edges and any unequal surfaces that would prevent efficient epithelialization and can cause poor healing and poor cosmetic results. So it is quite important. So just try to remember, you are going to always incise the skin perpendicular to the surface, and you're also going to, when you are suturing it, you have to put your needle, you have to make your needle enter perpendicular to the surface. So this perpendicular phrase is very important for you to remember. So any deshalving of the edges of obliquity is not quite good for you to have a very good incision. And the vasculature of the scalp becomes more thinner towards the midline. So therefore, the base of the incision should be close to the periphery of the scalp, like I have mentioned before. So this is another thing that you need to know about the scalp, is the dilated veins in this patient with hydrocephalus, and it's a very important thing for you to notice in a patient with hydrocephalus. There are a few points regarding decision making and planning. So I think that I need to mention it here. So this is also a slide that I've taken this from Neurosurgical Atlas. I'm really thankful to them for all these wonderful contributions. So with a few additions from my own side, I would like to tell you that these are some important things for you to know. So the Sylvian fissure, you have to assess it. It's like the surface marking is extremely important for you. So the Sylvian fissure marking is a line from, you can see this hash line. This is a line from the lateral canthus that is connecting to the point 3/4 of the very posterior and along the arc, traveling over the midline from nasion to the inion, and it approximates the Sylvian fissure. So you can see this is the lateral canthus, and this is the arc. This is from nasion to the inion, and this is the 3/4 points of this arc. And when you draw this line from the lateral canthus to this point at the 3/4, this approximates to the Sylvian fissure, which is represented through this dotted hash type of line. The other point important here is the central circus. So if you draw a horizontal line through the external auditory meatus, you can see this is a white line. This is the EAM, this is the external auditory meatus. So if you are drawing this line, this horizontal line through the external auditory meatus, a line at 45 degrees, you can see over here this 45 degrees. If you go again perpendicular, then this is 90 degrees, and the half of the perpendicular, the 90 degrees, is 45 degrees. So it is important for you to know, and it is not quite hard for you to assess this. So a line at a 45 degrees angle from EAM marks the location of the central circus. You can see this, you are drawing line, and this is the approximately the central circus. So it is extremely important for you to know. So the motor cortex is about 4 to 5.5 centimeter behind the coronal sutures. Another thing that you have to know, and the superior aspect of the motor cortex is almost straight superior to the external auditory meatus near the midline. And the central circus is also 2 to 3 centimeter posterior to the mid position of the arc, extending from the nasion to the inion. You can see over here, we have marked this line at this nasion to the inion arc. So you can see this is the central circus, which is about 2.3 centimeter behind this mid-position of the arc. So although significant variability exists, the angular gyrus is above the pinna. So these are some of the important points I really wish to tell in this course. A few lesions that you need to see when you are examining your patients include the spiral, tricholaminar cysts that are common fluid growth from around the hair follicles, and these are hemangiomas. You might have seen this. These are very important for us to know that you need to see on the when you are examining the scalp of your patient. And the dermoid scalp, this is a case I've taken from from Radipedia. So this is important thing that as a neurosurgeon you need to know. And this is a case of scalp mets from breast cancer. You might have palpated several of mets from on the scalp, and most commonly we have seen from the thyroid metastasis that make their way up, and you can palpate them. This is a frontal cutaneous meningioma case report. Frontal cutaneous meningioma. You might be able to have this. I'm just showing these cases for you to have an insight. Meningioma, so the brain tumor. You can see this is the meningioma that is invading the skull and the scalp. So this is important for you to know. And there's another thing that when you examine the patient, you should know is the Port-Puckey tumor, and it is one of the most serious complications of the frontal sinusitis, and it is characterized by osteomyelitis of the frontal lobe with an associated superior osteal abscess. So these are a few things that you need to see when you are examining your patient. I think that it is quite good enough for you to know. When I was just planning this, I just thought that a couple of things you should know, because when you are examining your patient, you need to have these differentials in your mind, and that will help you, I think, in a good assessment of your patient and management. Thank you. Going to the skull, I've taken this wonderful quote from Professor Aaron Cohen. It is: the skull is an entity in itself. It is a jigsaw puzzle of irregular bones and very specific bone atoms that combine to form a masterpiece. It is a helmet for the brain and a scaffold for the face. The skull is divided into neurocranium, which is the brain case, and viscerocranium, that is the facial skeleton. So here I want to tell you about the diploids. Okay, you can see the skull bones with the diploid, the outer table and the inner table, and in between this is the diploid, which is a journalistic term used to describe the spongy or the cancellous region intervening between the heart, outer cortical shell, and the brittle inner shell. So it should be noted that only one-third of children under the age of 3 years will have a diploid space detected by the CT scans, while the diploid space is visible in the anterior parietal region of the skull in up to 82% of children aged 3 to 5 years. So the thickness of calvarium and the presence of diploid space in children can aid in surgical planning for split thickness calvarial bone grafting when needed in calvarial reconstruction. So this is an important point for you to know. So I just try to highlight this thing. So I'm just trying my best to give you some insight when I'm going into basic neuroanatomy, that what can be a clinical point be relevant to all these things. So when you can see it in the CT scan, you can see this is the outer table and the inner table, and between them is this diploid. You can see over here this is scalp, and this is the zigzag area of the suture. So coming into this into the skull, so you can see over here, this is, you can see the forehead area. This is fake bone, is the frontal bone, and this is, this prominent area is the glabella, and this is the nasion and the nasofrontal suture over here. You can see, and this is the, these are the two nasal bones that are joined together, and this is the, between this lesser wing and the greater wing of the sphenoid. You can see this is the superior orbital fissure. This is the little, this slit is the superior orbital fissure. And if you can see over here, this is the optic canal for the optic nerve. You can see over here, this is going down right down here. So these are the few very important points for you to know. If you can see from this orbital rim, this is a little notch over here. This is the supraorbital notch for the supraorbital nerve. And this prominence is the zygomatic process of the frontal bone. This is the whole, I've seen that show you, this is the area of the orbit. And this is obviously this is the maxilla bone, and this is the frontal process of the maxilla. These are the contour process of the mandible that you can see over here. This is obviously the mandible. These are the mental foramina. This is the body of the mandible. This sharp edge is the angle of the mandible. You can see this corner. This is very prominent over here. And coming into nose, this is the anterior nasal spine. This is the middle nasal concha you can see over here. And this is, a perpendicular plate of the ethmoid bone. And again, you can see the glabella, which is a median elevation between the two superciliary arches. Glabella is present just above the nasion, which is an intersection of the internasal and the frontonasal suture, like I've shown you. These are the two nasal bones. This is the internasal suture, and this is the frontonasal suture, and it is just above the. Here comes the nasion, and just above is this glabella. It is a little, it's something which is a little elevated above it. So you can see overhead, see the nasion, this is a little bit inwards, while this prominence above this, a light depression, you may say, is the glabella. And this is the nasion, which is the bridge of the nose, which is the midline bony depression between which is where the frontal and the two nasal bones meet below the glabella. Now coming towards the lateral surface of the skull. So here you can see this is the frontal bone, and behind the frontal bone are the paired parietal bones. The paired parietal bones have this sagittal suture in between them, and the frontal bone it joins the paired parietal bone through this coronal suture, and these two parietal bones, join this occipital bone, and this is the lambright suture, which is between both of these. This is the temporal bone, the squamous part of the temporal bone. And here you can see this is the sphenoidal bone that you can see. It is the ala major of this the greater wing of the sphenoid. This is the anterior nasal spine, and you can see over here, and it is the zygomatic bone that you can see. This is the metaforamen that we have already shown. And this is the zygomatic arch that you can see over here. This is the external auditory meatus that we have talked about. And this is the mastoid process that you can see over here. This is the asterion. We are going to explain it. It's a very important point regarding, when we are performing the retrosigmoidal approach. And it basically, denotes the transverse and sphenoid spinous junction. And here comes, the pterion. Pterion is extremely important. And this is, you can see, this is an H-shaped of area, and I'm going to explain it more with you. This is the frontal bone, this is the parietal bone, the temporal bone, and the sphenoid bone, and these to come together here at the pterion. So the ilion is a tip of the external occipital protuberance, the midline bony prominence in the occipital bone. So the sutures of the skull are basically the fibrous joints with a fracture-like appearance found between the bones of the skull. Sutures are formed during embryonic development. They are sites for bone expansion, ensuring craniofacial growth during the embryonic, postnatal, and later growth periods. The cranial sutures ossify at different rates. Sutures of the adult scales are categorized as synarthrosis, and synarthrosis is a type of joint that, under normal circumstances, is immobile. So here we are with the sutures. I think I have already shown you before, but this is a better view. So you can see over here, this is the sagittal suture between the two parietal bones. Is the corner suture between the frontal and the two parietal bones. And this is the lambright suture between the two parietal bones and the occipital bones. So you can have a good idea about this. This is the most important thing that you should know, and have some good idea about. So this is again a closer view to show you these sutures, which are not quite prominent over here, over in the other pictures. So this is the frontozygomatic suture over here. It is the lateral wall of the orbit. This is the frontonasal suture located over here. This is the medial orbital wall. This is the infraorbital fissure, and you can see this is like a little from below and a little lateral. You can see over here frontozygomatic suture, the infraorbital fissure. You can see over here the pterygomaxillary fissure over here, the fracture lamina, pterygoidal lamina, posterolateral. So it is, you can see over here. So these are the important pony landmarks that I wish to show you. So wherever this is a, I've seen the sagittal suture, this is the coronal suture, and this is the lambdoid suture. So where the sagittal suture and the coronal suture join each other, this point is referred to as the bragma. And where the sagittal suture and the lambdoid suture join, this is the point is known as the lambda. So you can see the lambda is the meeting point of the sagittal suture and the lambdoid suture, and this is also the point of the occipital angle. So this is an important point for you to know. So suture, these are the suture which I have already told you before. The coronal suture is extremely important for you to know, and this is why you need to know about it. I think I have also mentioned it before that the coronal suture is very important to know to locate the motor area. So when we see that we know the coronal suture, then we can assess the mean distance of the coronal suture from the central sulcus, and this precentral area that lies interior to the central sulcus is the motor area. So this is how you can actually assess, have an idea if you know the side of the coronal suture to locate where the motor area is. So this is the point of clinical relevance over here. These are the this is the cranial synostosis, which is basically mature closure of the sutures. So regarding that, we need to know what is the approximate age of closure of these sutures because they are patent at birth. So the metopic suture you can see between these two frontal bones. This runs midline of the frontal bone, and it usually fuses without any skull defect between the age of 3 months and 9 months. So you can see over here the coronal suture that may begin to fuse by the age of 24, and the average suture closed between the age of 30 and 40 years. And then the squamosal suture, this sutures it closed between 30 and 40 years of age. The sagittal suture, the full operation will never occur. It usually occurs sometime between 30 years of age and 40 years. The suture has been seen to close normally at 26 years and also remain open to someone in their 50s. And the lambdoid suture, full operation will never occur. Sutures close normally between 30 and 40 years of age. And the frontal sphenoid will close normally by the age of 3 months. So these are the abnormalities that can occur from premature closures. You can see over here the metopic craniosynostoses. It is the synostotic trigoncephaly, but the metopic suture, and synostotic scaphocephaly, that is by the immature closure of the sagittal suture. The lambdoid suture, the synostotic posterior plagiocephaly, and if all sutures, open, if this deformational posterior plagiocephaly, and this synostotic anterior plagiocephaly, if there is only one coronal suture, is one side coronal suture, is a unicoronal suture that can lead to this type of deformity. You can see only one coronal suture uh, has been prematurely closed, while the other one is patent. And if there is a bicoronal suture, then it could lead to synostotic brachycephaly. So depending upon which suture have been closed prematurely, leads to the type of deformity. So again, if you see, if it is a metopic suture, it is trigonocephaly. It is because of premature closure of sagittal. It is scaphocephaly. If it is the lambdoid suture, you can see this plagiocephaly, and this this deformational posterior plagiocephaly is basically positional type of a case. So you have to differentiate between them. If it is a real a real plagiocephaly, or if it is just a deformational posterior plagiocephaly. And then you have this uni and bicoronal synostosis that can lead to if it is if you can just familiarize yourself with, and you think that a coronal suture has two parts, like lambdoid suture has two parts, if you can see. So in that case, if the lambdoid suture is located posteriorly, it can lead to posterior plagiocephaly. Similarly, if because the coronal suture is located anteriorly, it leads to anterior plagiocephaly, and if both of the coronal sutures are closed, it leads to this brachycephaly, this synostotic brachycephaly that is seen. This is the pterion. Like I have told you before, it is extremely important for you to know. It is an H-shaped bony neurological landmark that is found at the junction of the frontal, sphenoidal, parietal, and the scamoso part of the temporal bone. And it is located approximately 4 centimeters superior to the zygomatic arch and about 3.5 centimeter posterior to the frontal zygomatic suture. So you can see over here, I have shown you this before. This is the frontal bone. This is the parietal bone, this is the sphenoid bone, the greater ring basically, and this is the scamosal part of the temporal bone. So the here is, you can see this is an H-shaped type of thing. You can see it is where these four bones unite, and this is known as pterion. And pterion, you might have, because if you are a neurosurgeon or a vascular trainee, you have a lot of think about the pterion. It has so many hypotheses. The pterional craniotomy is a world-class approach of neurosurgeons, and it is centered around this pterion, and it is also the weakest part of the skull, and it overlies the anterior vein of the middle meningeal artery, and a blow to this can lead to extradural hematoma. So these are some points of clinical relevance that you need to know about this. So in addition, it acts as an important landmark for locating the Broca's motor speech area and the anterior wall of the insula and middle cerebral artery, and it lies in close proximity to the middle meningeal artery, and in the left side to the motor Broca's motor speech area. So this is important in surgical approaches to the anterior and the middle cranial fossa, and it is generally located to two finger best above the zygomatic arch and about a 3/4 posterior to the frontal process of the zygomatic bone. So the pterion forms an important landmark in pathological, pathological tissue and many structures that are closely associated with it, including the optic nerve, and the orbit, and the sphenoidal region, the middle cerebral artery, particularly the aneurysm and trauma to the middle meningeal artery. Apart from its importance as a surgical landmark, it always can be a guide for determining the age and the gender and race, archaeological and forensic specimens. The pterion transcranial corridor is used to treat aneurysm involving anterior circulation, basal effects in the proximal segment of superior cerebral, posterior cerebral artery, AVMs, and scavenous hemangiomas of the basic forebrain, anterior and middle skull-base tumors, gliomas, the frontal pivotal temporal, aperture, insula, mid-basal temporal region, cerebral peduncle, intervertebral, and also the orbital region. So it is increasingly important. So there are the classification for pterions as well. So based upon the bones articulating, it can be this type 1 sphenoparietal. You can see over here, this is the A, that is sphenoparietal, where you can see the sphenoid and the parietal bones are in contact. So it is a suture pattern with the sphenoid bones articulate to the parietal bone directly. Number 2 is the frontotemporal. You can see basal here, B in bare here. The frontal bone and the temporal bone get united directly. So this is the frontotemporal type. The third is the stellate type. It is in D over here. You can see that these all four bones, the sphenoid, temporal, parietal, and frontal, they come together. And this is like a star type of a configuration that you can see over here. This is the stellate type of pterion. And this is the epipteric pterion, because you can see this is little bone over here. This is shown in E. And this is known, like a sutural bone between the parietal and the sphenoidal bones. And this is known as the epipteric. So stereo, like I have shown you before, it is on the lateral aspect of the skull, forming the junction of occipital, temporal, and the parietal bone. You can see over here, it is very, very prominent over here as compared to the other pictures. So you can see over here, this is the parietal bone, this is the occipital bone, and this is the temporal bone, and this is area. This is the asterion. This is very, very important in the retrosigmoidal approaches. You can see over here, it is one of the most crucial landmarks to identify the retrosigmoidal approach, because it is often used to estimate the transversinus sigmoidal transjunction. And this is the posterolateral view of the left sigmoidal and transversinus in the relation to the osseous landmarks. Exposure of sigmoid sinus anterior and inferior to the asterion and its connections to the mastoid and mystery vein, and exposure of the transversinus running under the superior nuchal line. So you can see over here, this is the lambert suture. You can see over here, and this is the deroping. This is sigmoidal sinus, and this is transverse sinus. You can see there's a confluence of both of these, and where they have not removed the bone, you can see this is the asterion, and this is the sigmoidal sinus that you can see over here, and underlying is the transverse sinus. So when you remove this area, you can see there is a junction over here of these sinuses. So the name Styrian derives from Greek and it means star. Additionally, it was also the proper name of the Cretan Minotaur. In anatomy, it is defined by the three suture junction of the lambdoid, occipitomastoid, and the parietomastoid suture with the occipital temporal and the parietal bones meet. Its reliability as a superficial landmark for the transverse sinus sigmoidal sinus junction for surgical approaches to the posterior fossa can vary in different patients. So the styron can be located superficial, inferior, or superior to the transverse sigmoid and junction, or transverse sigmoid junction, sigmoidal sinus, or the transverse sinus. So it is a little variation. So it is observed that the styron is located superficial to the lateral half of the transverse sinus, transverse sinus, and directly superficial to the transverse sinus junction and inferior to the transverse sigmoid sinus junction in the lateral posterior fossa and superior to the transverse sinus sigmoid sinus junction in 63, 1, 22, and 14%. That is, it is located superficial to the lateral half of the transverse sinus in 63%. It is directly superficial to the transverse sinus sigmoidal sinus junction in 1%. It is inferior to the transverse sinus sigmoidal sinus junction in the lateral posterior fossa in 22% and superior to the transverse sinus sigmoidal sinus junction in 14% of the patient respectively, according to one of the according to some of the recent papers is the meta-analysis. In general, from the styron, the lateral transverse sinus is located directly underneath. The transverse sinus sigmoidal sinus junction is about 1 centimeter anteriorly located, and the sigmoid sinus in the anterior-inferior direction, and the posterior procedura is in the posterior inferior direction. So in the standard retrosigmoidal approach, the most important burr hole, which should expose the junction of the posterior fossa dura and the margins of the adjacent transverse sinus and the sigmoidal sinus, is conventionally placed over the asterion or slightly below it. However, it is also argued that the following techniques are superior to this conventional method I have mentioned before, which I have just mentioned. So in the Taranashi technique, placing the burr hole about 6.5 mm inferior and 6.5 mm interior to the styrion, and in the Rebus technique, at burr hole 10 mm anterior to the styrion, the superior edge of the burr hole adjacent to the parietomastine suture are the most suitable approaches for the placement of initial bore in the standard and extended retrostigma approaches, respectively. So these techniques are considered to be better. Um,